Hi, I'm Ralph Rubin, the Baxley Professor of Pathology here at the Johns Hopkins University School of Medicine. Welcome to the Mario Molina Studios, where we document Johns Hopkins history. It's my pleasure today to have Lisa Maragakis here with us, one of the leaders of the COVID-19 response here at Hopkins. Lisa, welcome.
Thank you so much for having me.
My pleasure. Looking back, is there anything in your training or your experience that would have led you to anticipate the COVID-19 pandemic?
Well, in fact, of course, we didn't know the details of what would unfold, but any infectious disease physician knows that pandemics are periodic events. And so, yes, we did anticipate that a viral respiratory illness creating a pandemic was a very real possibility, if not a certainty. So a lot of planning had gone into pandemic preparedness over the years, and of course we weren't the only ones. But again, this was a well-documented historic phenomenon, so we did know that it was likely. I think most of us thought that it would be an influenza virus, although we had a little bit of a preview in the early 2000s with the SARS virus, with trouble with coronavirus. So it wasn't completely unexpected.
And amazing. What were your thoughts when you first heard of the outbreak in China, in Wuhan, China?
Well, hindsight is 20/20, but and so I don't know if you'll believe me, but my team and I really did take it very seriously from the earliest reports. So again, in infectious diseases, in infection prevention, we're very attuned to world events and outbreaks, unusual clusters of disease. We have mechanisms to alert us to those kinds of phenomenon. And so in late 2019, we were quite alarmed by these reports, especially how rapidly it seemed to be spreading, the severity of illness. And of course, we can say there wasn't a lot of accurate information coming out of China at that time, but what was coming out was quite alarming. So my team and I actually, over the winter holidays, over Christmas and New Year's, we're watching very closely and came back after the new year in January of 2020 and convened our own incident command for infection prevention and emergency preparedness, and began in January really making plans in case the pathogen came to our shores, which of course now we know it did.
Which brings me to my next question is, what were your thoughts when the first suspected case came to Hopkins?
Well, of course it was distressing for everyone, but as my last answer tells you, we were expecting it by that time. So most people think, oh, the beginning of the pandemic, March of 2020, but again, we had been in an incident command structure since January, watching very closely, seeing the reports of all of the spread. So I think by the time we had our first case here at Johns Hopkins, we knew the cat was out of the proverbial bag, so to speak, and so we knew that this was inevitable at that point. However, you have to escalate your response once you actually have a pathogen in your own jurisdiction, and so that really did mark a turning point for us. The first case that was admitted here at a Johns Hopkins facility was someone who had traveled from New York, and we all were watching with horror the events unfold in New York City at the time, and desperate people leave areas of trauma and seek help elsewhere, and that's really how it started for us.
And so the first patient arrives. What was the status of clinical care at the time? What was available in your war chest, if you will?
Right. Well, I know you've had the opportunity to speak with Dr. Brian Garibaldi as well. So we have a biocontainment unit. We had by then a lot of preparation in place in terms of infection prevention, our air handling procedures, our personal protective equipment. So I would say we were prepared as we could be at that point. But from a clinical standpoint, of course, it was a novel pathogen. So no one really knew what to do, or we didn't have any therapeutics, of course. So it's supportive care. something that, of course, we do for patients all the time, critical care, supportive care, even when we don't have targeted therapies. But that's really what it was. And quickly the numbers outstripped our relatively small space in the biocontainment unit. And of course, the rest is history, as they say, how many patients we needed to care for. So it rapidly escalated. It was very frightening, but very encouraging, I think, to see how our colleagues rose to the challenge.
And then what were the challenges in developing clinical care and deciding what to use and what not to use? There must have been tons of information coming from multiple directions, multiple medical centers. How did you then narrow what we were going to do here at Hopkins?
Mm-hmm. Well, our approach was informed certainly by what we were hearing from other medical centers out of New York and really around the world. And I'm speaking now from both the clinical side of things as well as the infection prevention measures. I'm responsible for infection prevention, so that was a big responsibility to make sure not only that we could take care of the patients and try to save as many lives as possible, but also that we could keep our personnel safe in the process. And one of the turning points was really that question of whether the virus was transmitted by the airborne route or by the droplet route. And national guidelines at the time, really, early in 2020, the CDC came out and said that we needed to protect against airborne transmission. And of course, that debate continued on, and there's a lot of science around that now. But at the time, it ultimately was the national guidance and also erring on the side of caution, because when you have a new pathogen, you don't know, you need to protect everyone. And there was a tremendous amount of fear, a lot of bravery, a lot of courage, a lot of dedication and service, but also a lot of fear. So we erred on the side of caution, used airborne isolation, respirators, and thankfully all that early planning that we had done positioned us well to protect our personnel, even though the country and the world faced a critical shortage of personal protective equipment early in the pandemic and for much too long.
So that must have been, in your role, extremely challenging, also because you have kind of public pressures, if you will, whether we should be masking in the hall and how to, on one hand, protect people, but also not frighten them or overreact. How did you manage that balance?
So that is one of the biggest stories, I think, of the pandemic, not just for me and my team and our response here at Johns Hopkins, but really nationally in the United States and worldwide. And it's one of the things that I wish I had studied history more thoroughly before finding myself in this leadership pandemic response position. And I say that because, as we all know, it was a very fraught issue. The guidelines, the discussions over masking, the discussions over any kind of restrictions in broader society and even within healthcare about air handling and personal protective equipment in particular, and then again about vaccines later when we had one. The reason I say I wish I had been more aware of history is that the history of pandemics shows us that this is the critical issue. So there's the scientific and clinical part of responding to a pandemic or a novel pathogen, and then there's the much larger part, which involves sociology, psychology, political science, history, economics, and so many things that are really beyond our control in medicine, but determine the overall community response. And I often thought during the pandemic response about the challenges faced by officials when a large storm is coming. And of course, that's more of like a point in time than this giant prolonged crisis that we had over the pandemic. But you face some of the same things. Some people are resistant to evacuation orders, for instance. Some people rush to the beach just as the beach is closed. And we saw some of that same behavior. So I do think I would like to put in a plug for future pandemic planning to involve multidisciplinary groups that can help craft responses and communication strategies that would help with some of those factors.
I can only imagine the pressures on Fauci at the time. It's unbelievable.
Right.
On a more personal level, obviously you're a physician and in charge of infection prevention, but also a human being. How did you feel? Where you mentioned fear and the other emotions associated with it. I'd love to learn more about that.
Oh, wow. Well, it's a very long period of time that we responded. I think I was naive at the beginning. This is another thing that knowing history would have taught me, that it would be a several years long event, not a several months long event. So at the beginning, I didn't know that. So I would say so many of us had a tremendous burst of energy, which is, I've learned, normal in an emergency response. And in medicine, most of our instincts is to rush towards the problem and find solutions. So I was energized, I guess I would say, by the colleagues who all came to help. It was a very proud moment for our institution to see everyone contributing their expertise, their time, their energy. We were extremely busy, but it was very energizing to really tackle a problem and put those pieces together to keep everyone safe and provide clinical care and testing and all of the great work that was done. So that's how I felt initially. We did have, I have a colleague who came around early in those days who warned us that the natural history of responding to an emergency does have that initial surge of energy and enthusiasm, camaraderie, and that over time, more negative experiences take hold. And I didn't really believe that at the time, but we did experience that too. So as it wears on, people become frustrated, people become tired. Some of those negative factors that you mentioned from society at large, vilifying some of the decisions that we made, it wears on people. And so we did experience that too. But initially, an incredible burst of energy and feeling that all of the preparation that we had done, really was a call to service, to provide that, to protect everyone.
Amazing. And you mentioned this arc, the kind of the rise of the excitement and then the fall. As a leader, then you not only had to deal with your own emotions, but also those of your faculty and staff who were, on one hand, trying to save lives and risking their own life. How did you help manage their own fears and anxieties?
Well, I hope I was able to do that. I think that communication is critical in these situations and any kind of crisis situation, to make sure that people feel informed, that they know that decisions are being made based on the best available evidence, that you there's a crisis communication principles, that you are early, you are out there first, you're being transparent about how you're making decisions. So my team and I really tried to do that. As we've discussed, there were some negative emotions swirling around, and I really came to believe that fear was the main driver of those, even when people looked very angry and accusatory at times. I do think that the fear was the common denominator there. Overall, I would say that people were extremely courageous, brave, and selfless in the response. But it was difficult, I think, at times. And I'll point to one real challenge. I mentioned it earlier, and that was when we did not have enough personal protective equipment. And a shortage of anything, particularly a critical item like a respirator when you have an airborne pathogen, is a true challenge because we all know how contentious masking is. Well, that happens in the context of plenty of masks for everyone, and then you have the luxury of having arguments about whether you can make me or you can't make me and whether we should or shouldn't. But once you have a shortage of something, the psychology shifts and suddenly everyone wants one. And then there's vying for that limited resource. So management of limited resources was one of the biggest challenges, and making sure that we directed those resources equitably, evidence-based, and guarded the resources so that they wouldn't be pilfered, and that they maximized the protection to those who were really on the front lines with the biggest risk. That was challenging.
I always loved your management style in different meetings when someone would say something very aggressive or something, and you always responded, "Thank you for that comment," or "Thank you for that question," before answering. And I think it showed incredible equanimity in your responses.
Thank you.
You've mentioned the importance of teamwork in the response. I wonder if you can delve deeper into that, the teamwork here at Hopkins, and how important that was and how it manifested.
Oh, teamwork, we could not have done what we did without teamwork. And I am so proud of our organization for the teamwork. And it was an incredible example of people coming from every different angle and bringing their expertise to the table. And watching that was an incredible thing to see. Just to realize skills, resources, ideas that people had that I had never been particularly aware of, and how everyone brought that collectively to the table to make things work, whether it was the administrative expertise to work out the logistics of how we were going to deliver vaccines, the scientific expertise to answer some of the basic questions about this new pathogen, the incredible efforts on everyone's part to develop new testing, to implement that new testing, and just to take care of the patients and really learn while you're on the job, taking care of critically ill patients, many of whom were dying, and get better at it every day.
Put in a shameless plug for pathology.
Yes.
Can you comment on the impact, obviously, Heba Mustafa and Karen Carroll, very early on developing testing here at Hopkins? What impact did that have?
Oh, it was just an amazing, I can't even describe the magnitude of the impact that it had. And yes, Dr. Carroll, Dr. Mustafa, just really out ahead of the curve. And one thing we haven't talked about here is the dysfunction in our country that we also had during the pandemic response, in some part due to lack of adequate preparedness for some of those factors that I mentioned earlier, and also the fact that the levers of control were really in the hands of people who turned out to not take it seriously, or perhaps leverage short-term political gains rather than thinking of what was best to do. But whatever the cause, we found ourselves in a position where we didn't have enough personal protective equipment. We didn't have testing to detect who had the virus. We didn't have hand sanitizer and disinfectant. So this is a circumstance that I had never anticipated. In those early days, we felt like we were on the front lines and we were holding the line and getting ready, but I truly expected reinforcements to arrive, to bring those kinds of supplies to us. And when they didn't arrive, that was extremely disappointing. So your question was about the testing. And the testing was one of the first signals, PPE and testing, the first signals that no outside help was going to save us from this. And I remember running into Dr. Carroll in the parking garage one morning, and she stopped me and we talked briefly, and she said, "I want you to know we are on this, and we are developing a test, and we are filing a mountain of paperwork." And that might not be tall enough to estimate how much paperwork they had to file to get permission and regulatory approval to even implement that test. So they jumped through an enormous number of hurdles for the first test and then many other platforms. And basically the answer is we would not have had the ability to tell who was infected and who wasn't for months if we hadn't had their test. And not only at Johns Hopkins, but really in the state of Maryland. So they did a tremendous job and had an enormous impact.
Great. And you described the advances in testing, and you mentioned that when the first patient came, there was really only supportive measures. What do you think were the kind of the major improvements in patient care that occurred over time to bring us to where we are today?
Oh, so many. And I mentioned learning on the job, our clinicians as they were taking care of the patients. And I'm sure that those critical care physicians who were on the front lines would have more examples than I do. But the things I know are very early on, there was the use of treating patients in the prone position to improve their lung function. And that was something that had been done on rare occasions for extremely ill critical care patients, but never to the extent, I think, that it was seen in this response. So that's one thing that within the realm of clinical care before we even had therapeutics that happened. And there were many others, I think, mostly around maximizing pulmonary critical care function and trying to help people survive. Of course, clinical care also relied upon the data that showed the risk factors. And so we could err on the side of caution, hospitalize patients who we knew were at risk for the severe consequences. Because one of the things that happened is patients would deteriorate relatively late in their clinical course. And so you had to develop kind of an index of suspicion for which direction an infection was likely to take in a given patient. So that was another advance. As I said, there's probably many others could point to. But then jumping forward, finally to have an oral medication or an IV medication, an antiviral. So, and of course, we also know that there were a lot of debates and red herrings about, what was and was not effective. But that was a game changer to have antivirals. And then, of course, the vaccine. Amazing. And that's a story of preparedness as well, because there's no way that a vaccine like that could have been available so quickly. And I know it felt like it took a long time, but in the history of vaccine development, that was a landmark, most rapid by orders of magnitude vaccine development, and really was built upon years of preparation and work that had gone on ahead of time.
Yeah, I just got my 2023-24 last night.
Yes.
But in your role then,
Yes.
rolling it out, talk about pressure, right? Where it's a limited resource and everybody is scared and wants it. What were kind of the principles you brought forward in thinking about how to, once the vaccine became available to Hopkins?
Oh, yes. Again, the limited resource did come into play, and who would be first? And we tackled those questions with a multidisciplinary team led by Dr. Alan Kachalia, our limited resource response group. And I learned a lot through that process of bringing together stakeholders and ethicists and multidisciplinary stakeholders so that we could hear everyone's perspective and try to together arrive at a consensus hierarchy and plan for rolling things out. And that was difficult, but really eliciting the frontline knowledge of those stakeholders was critical, and learning from our ethics colleagues, our bioethics colleagues, some frameworks for considering these issues. It was contentious, and as I mentioned earlier, when you have a limited resource, suddenly everyone wants it, and you have fewer of the conversations about mandates and things like that, but you just really have this pressure to have access to the limited resource, and that's challenging.
Yeah, I remember different emails being, if you go to somewhere and and they have opened a packet of 8, and there are 3 left over. You can get lucky if you hang out at the pharmacy at the end of the day or something. There were all these strategies that people had to try and protect themselves, which is such a natural feeling.
Well, one thing I could mention in regards to that as well is that there were national efforts to think about this as well. And that is very helpful if you can have a framework for instance, the CDC and others saying that healthcare personnel should be at the front of the line. So we were working within our medical system to determine amongst our own personnel who should get the vaccine. But at least that principle had been laid out at a national level, that healthcare personnel should be at the front of the line, because those are also difficult conversations and not a given. The larger society, and even within Johns Hopkins, we had conversations and people who were unhappy because they were part of Johns Hopkins University, but not part of the School of Medicine, and a lot of tension there about how those decisions were made, who was making the decisions, and how equitable everything was. So it's not easy.
And this obviously starting with an unknown pathogen and ending with a vaccine and treatment. Can you describe some of maybe the research efforts here at Hopkins, those that you participated in, to help us understand the virus better?
Oh yes, and I'm sure there's many more than the ones that I'll briefly mention here. But Dr. Brian Garibaldi, I hope, was able to describe to you what he did. He was a critical leader in putting together a clinical research group to gather data from the patients, because we all know that existing known pathogens, you go to the literature, you have a lot of data about the epidemiology, the risk factors, the pathogenesis, the clinical course. This is a new pathogen. We needed data on all of that. And some of it changes as the virus mutates and different strains come through. So just the very basics of the data. What is this pathogen doing, and to whom is it doing it, and how can we predict and then therefore step in and interrupt the severe consequences? So that was critical research. Also basic science research and leveraging, scientists who had studied coronaviruses their whole life and probably also didn't think that they would be thrust into the spotlight like this, but leveraging their expertise, and not just the coronavirus experts, but viral experts in general, immunology, trying to understand how our immune system was responding to the virus. So much basic science research, and then also clinical studies really looking also at the immune response, trying to understand how much asymptomatic disease was out there, how much asymptomatic spread, and looking at antibodies, for instance, to understand how immunity might be rising in the population before we even had a vaccine. So those are just some of the examples. But a tremendous amount of work, and many people pivoting their research laboratories and mechanisms to help with this.
One question I always had in your leadership role, as this research is coming out, some of it is coming out in peer-reviewed publications, some in bioRxiv or something that hasn't been peer-reviewed.
Right.
How did you balance that or choose which to follow? You want to be ahead of the curve because the need is so great, but on the other hand, you don't want to jump ahead of a paper that's not been peer-reviewed to make a life or death decision.
True. Well, it's so true. And of course, we're evidence-based here at Johns Hopkins, and so we value peer-reviewed, published literature extremely highly, and that whole process. That being said, we were in an emergency response, and we needed every shred of evidence that we could find. There was a whole change, one that I think will endure, about how people released information. And so a lot of scientific information was released early, online on various platforms, making it available to everyone before it had been fully peer-reviewed. Now, there was, some screening process put in place, and that's a whole different way of sharing scientific information that, as I mentioned, I think it will endure, and I think we'll have to find a new balance for, really how that works. But in the midst of the crisis, the need for information rapidly really trumped, the old way of doing things that had that longer delay.
Yeah. Now, but looking back, what's your proudest moment? And I know the pandemic's not done, but to date, what's your proudest moment?
You know, I would say I don't think of it in a personal pride sort of way, but when you ask that question, I think of pride in Hopkins. And I think back to when I came here as a medical student and what I heard, which was that we want to advance the science of medicine and care for patients and teach the next generation. So we have that tripartite mission. And I think our response exemplified that approach. So I am proud of that. I'm proud of our organization, both for the preparation that we did that positioned us well to respond to this, and then how we responded in the moment, really throughout the organization. I think the leadership was extremely bold in putting resources behind what needed to be done, what was the right thing, even before we knew what reimbursement might be available and all of that. We were just trying to do the right thing. And the leadership supported that with resources, even in very financially insecure times. And then I've mentioned all the heroic, wonderful work that was done by the team. So that makes me very proud. The other thing I would add is, and this is part of Hopkins' tradition and mission as well, is not only taking care of business of what we needed to do here and for our patients and for our community, but also being leaders nationally, internationally. And so some of the, if you wanted a moment, it would be some of the moments that we had opportunity to be that beacon for the world, testifying on Capitol Hill with a panel of experts from our organization that was able to provide the data dashboard that was used around the world, the principles of infection prevention, the principles of emergency preparedness, and some of the information that was starting to come out of the research and the clinical picture. So I think that those were the moments really where I felt like we were able to serve a very broad audience that needed information and looked to us for leadership. So that's what we're here for. Right.
I remember you on the national news, right, in that speaking on several occasions. So that must have also been a pressure on you, but as you said, an opportunity to serve.
I viewed it as mostly an opportunity to get messages out and correct the record because we were already starting to see a lot of misinformation out there. Right.
Yeah, fantastic. Flipping the coin over, what about your most fearful moment?
Well, I mentioned earlier that fear, I think, was a huge driver of some of the bad behavior, some of the negative emotions that we saw amongst members of the public and some of our political leaders and some of our colleagues, quite frankly, from time to time. I think everyone was afraid. It's natural to be afraid of something deadly. I alluded earlier to some of my biggest disappointments, and I guess one of the biggest fears was really when we had insufficient personal protective equipment and respiratory protection in particular. Now, we had done planning that included reusable respirators, things like the powered air purifying respirators that have the hoods that go over and the HEPA filtration, things that basically are like gas masks and can be cleaned and reused. And that was a critical preparation step that we had taken early on, actually years before the pandemic, and then we bolstered it in that January to March period, and we're able to provide that. So I think that alleviated some of the concern, but facing a deadly pathogen without the equipment you need, that would be the height of fear for me.
Thank you so much. Is there anything else you'd like to tell us about?
You know, this story, I think, as we know, is still unfolding. I think a lot of us, including myself, are still processing the story and what it means. I do think, and I thought throughout the response, that we have a responsibility to future generations to document what happened. So thank you for having this forum, and also to help inform their preparations. So I guess if I had any wish, it would be, to be a part of that, of the pandemic planning, but also conveying some of these lessons learned and the critical things so that maybe next time people can be even better positioned. And with the viral pathogens, you never know. It could come sooner rather than later. It may still be us. So I think in processing, internalizing some of those lessons and trying to better position ourselves. And when I say that, I mean humanity, really, because some of the failings, if you go back and read about the 1918 flu pandemic and other pandemics of infectious disease, some of those same factors came, and it's in our human nature. And we need to be prepared to deal with it in order to have a more effective response.
Thank you. I think we all reread The Great Influenza, and that book,
Right.
and the parallels you say are just amazing. Well, I wanted to thank you personally. I'm in awe of everything you've done, and
Thank you.
we're all deeply appreciative. So appreciative. Thank you so very much. A real pleasure talking with you today.
Thank
Thanks.
you. Thank you for this opportunity to share. Thank you.